There are some patients that just stick with you. And the one I'm thinking of was just really sad, and it made me want to learn more about what was going on to really focus in on what we can do for management in the field. What I wanted to dive in on was peripheral arterial disease and acute limb ischemia. What is peripheral arterial disease? Atherosclerotic plaque formation leading to progressive luminal narrowing and flow reduction. So when perfusion can't meet metabolic demand, then you have ischemic muscle pain called claudication. Chronic hypoperfusion leads to tissue loss, ulceration, and gangrene. And on physical exam, these patients might have diminished or absent distal pulses. They might have cool, shiny skin with loss of hair. They might have dependent rubor or pallor with elevation, delayed cap refill, or even arterial ulcers. And how do we diagnose PAD? So at bedside, you can do something called an ankle brachial index. And this is when you put blood pressure cuffs on both their arms and their legs. You can do a duplex ultrasound, which is first line for localization. You can also do a CTA, and this helps with anatomic mapping before an intervention. You can grade your degrees of peripheral arterial disease. So there's an algorithm based on their grading of how to intervene. So you can start with lifestyle modification, things like smoking cessation and supervised exercise therapy. Then you can discuss medical therapy. So things like an antiplatelet like aspirin or clopidogrel. If med management doesn't work, you would step up to revascularization. And then finally, if all else fails, then really the only option is amputation. Acute limb ischemia is a vascular emergency. And this is a sudden decrease in limb perfusion, less than 2 weeks, that threatens the limb viability. They might have an abrupt occlusion, leading to decreased distal perfusion and tissue hypoxia, leading to anaerobic metabolism and acidosis, leading to myonecrosis, usually within 4 to 6 hours if untreated. So it can be embolic. This is about 50% of the patients. This can be from AFib, a mural thrombus, a prosthetic valve, leading to abrupt occlusion of a previously normal artery. It can also be thrombotic. This is about 35% of patients. And this would be like an in situ thrombus of a pre-existing PAD lesion. You can also have traumatic or iatrogenic acute limb ischemia, and this can be from a vascular injury, dissection, or a graft thrombosis. Rarely, you can have an aortic dissection extension leading to limb ischemia. These patients present with the 6 Ps, just like compartment syndrome. So pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia. So they would have sudden severe limb pain. This is the most common. A late finding would be muscle necrosis. Presence of sensory or motor deficits indicates threatened viability. Get your Doppler and go and look for those pulses. And then they might have modeling with fixed staining, and this indicates a non-viable limb. How do we diagnose these patients? A CT angiogram with runoff is the gold standard if the diagnosis is uncertain and the limb is still viable. Do not delay therapy for imaging if the limb is clearly threatened. So how do we manage these patients? Your immediate actions would be a heparin bolus and then an infusion. And this is to prevent propagation of the thrombus. And then you'll want to get a stat vascular surgery consult. There's a Rutherford classification of limb ischemia that determines definitive therapy. For class 1, you would want non-urgent angiography plus or minus thrombolysis. For class 2A, urgent revascularization, which would be catheter-directed thrombolysis or embolectomy. Grade 2B, immediate revascularization. Class 3 is irreversible. And unfortunately, these patients have to undergo amputation. What are your adjuncts for care here? So thrombolysis, like TPA and TNK, do have a role here for a fresh thrombus. So if it's less than 14 hours and in a viable limb. Also, an embolectomy for an embolic occlusion, a bypass if there's extensive thrombosis or failed endovascular approaches. And then a fasciotomy is also often part of this care plan if there's a reperfusion injury.